Welcome everyone to the Underserved Population Network events today. We're glad that you could take some time out of your day today for one of our sessions. From HHQI, I'm Misty Kevich, one of the nursing coordinators. We also have on the call today with us Andrea Lasky, as well as Misty Dyke and Shannon Wright, our director. So we want to welcome you, and we're going to start and jump right into our presentation today. I will first give you a couple housekeeping. For Q&A, as you think of the questions, please type them into the Q&A box or the chat feature. We'll gather those during a Q&A session later. But like I always say on the calls, when you think about it, just type it in so that it's out of your mind. You can continue to learn and take in the information that we have for today's presentation. So on the next slide, I just have a little schematic of cross-setting collaboration, just to kind of get our juices starting. You're on the call because you're interested or involved in collaborations, and I wanted to just kind of bring us together. We know that to do quality improvement for patient care, especially when we're talking about reducing hospitalizations, improving med management, even care transitions, and chronic disease management, it really does take a village. And we can't do it alone because it just doesn't work, one setting. We have to, but unfortunately, so many times we still find ourselves in silos of care, home health, hospitals, physician offices, etc. But we must work together to be able to do collaboration together. So we need to reach out so that we can work with each other. So the next slide, I'm going to introduce our speaker today for the population health management from the home health perspective. Today's speaker is Sharon Fisher. She is a healthcare senior executive specializing in bridging partnerships between acute and post-acute providers. Her experiences span across the full continuum from acute care health systems to post-acute providers and payers. This exposure allows a unique perspective for episodic care management and positioning for global payment models. Using strategic planning and process improvement approaches, Sharon has the ability to bring in stakeholders to gain a shared vision and implement complex healthcare initiatives to drive down costs, improve efficiencies, connectivity, and transparency across the continuum. And that is the environment that we are living in and growing into with healthcare reform. She does not believe complex issues need to be a complicated process. She finds hospitals, PHOs, hospitalists, and home care partnerships are key elements in her work to focus on readmission initiatives between hospitals, rehab, and home, and primarily focused on chronic disease management. Currently, Sharon is engaged in two key innovative initiatives in Lowell, Massachusetts. She has been the project lead for a 3-year population management grant through Blue Cross Blue Shield of Massachusetts Foundation. The grant was awarded to Circle Home, Inc., which was formerly the VNA of Greater Lowell. The goal is to demonstrate the ability to manage a population typically underserved and not homebound. So we can kind of take from that from our MA patients, populations that we have, as well as general principles that could be applied across all settings and populations. The second innovation project that Sharon is involved with is a health system, Circle Health, as an integrated community healthcare delivery system. She's going to lead the development of strategy and implementation of a post-acute preferred network, and that will comprise of skilled nursing centers, home health, hospice, acute rehab, and long-term acute care. This unique system unites providers and organizations across the continuum of care and creating that shared vision for providing convenient and affordable access to complete, connect care. And with that, I'm going to turn it over to Sharon.
And I'm excited to share with you our program that we've been near and dear to our hearts for the last couple of years. And just a little bit of background on how this came to be. Blue Cross Blue Shield of Massachusetts Foundation actually had 14 grants that they were awarding throughout the state, all focused on making health care affordable. So several of them have been focused on behavioral health management, working with medication reconciliations through community health centers, but they had one specific grant that was focused on these chronic disease patients and helping the folks to manage their disease. So the one grant for the chronic disease was focused on COPD, CHF, and or diabetes. So the VNA of Greater Lowell at the time now has changed their name because they are now affiliated with the Circle Healthcare system that's here in Lowell, Massachusetts. And so that now you'll hear me refer to it as Circle Home. But at the time, they were awarded this grant, and they were the only home care to do so. So it was a really big honor for the organization and a big challenge to take it on. The demonstration was to last 3 years in totality, but for 1 year, which we are now in our last and final phase of, is to monitor these folks that we were able to enroll and monitor them and measure how they're doing. So some of the goals that were outlined within the grant were to reduce their readmissions to the hospital and to also try to reduce the amount of emergency visits that they've had. Also to measure what their A1C was for our diabetic population prior to the grant, and then also in the middle of the grant at the 6-month mark and also 12 months. And then to also measure through a couple of different ways on some self-management of the chronic disease through PHQ-9s and some self-efficacy types of survey tools, as well as satisfaction surveys were really important to us. So these were the goals of the grant. You can go ahead to the next slide. The parameters to make, or the profile to approve someone to be part of the grant was, number one, the goal was to try and get 100 people to voluntarily participate that had one of these three or a combination of these three diagnoses. And as many of us in healthcare know, most people with CHF typically have something else going on, and a lot of folks with diabetes have a couple of comorbidities with them. So it wasn't a surprise to see one or more of these chronic diseases with each of our participants. The unique thing for a home health agency was the next profile and parameter, which was the folks needed to be non-homebound. So if you think about those of us working in a home health environment, you know, the number one criteria to skill them for your services is they must be homebound. So it was a bit of a mind shift for an agency to try to figure out where we're going to find these non-homebound folks, and we'll talk about that in a little bit. And they were all adults, so 21 and older, and we've had several folks that are in their 30s in the grant, and we have several that are in their 80s. So we do have a pretty wide spectrum. We did hit the 100 participant mark the first week in January, so we're very thrilled about that. And as I mentioned before, they all had to have at least one hospitalization prior to the grant or an ED visit, unless they were diabetic. And if they were diabetic and had not been in the hospital, but if their A1C was greater than 8, then that qualified them for enrolling into the grant. Now, the other piece, because this grant was really focused on the underserved population, the Blue Cross Blue Shield Foundation really felt it was important to try and limit the enrollment to 10% of the Medicare population. Now, with that said, now that's for the grant, but I can tell you there are many folks out there that have Medicare that still can't afford the services that they really need in the community and are struggling to pull that all together. So we know going forward that this can transcend to a much larger population. But for the purposes of the grant, we really limited the Medicare population and focused more on our folks with Medicaid or Mass Health here in Massachusetts, or those with dual eligibles were also welcomed to be part of the grant. So that was a good thing. We also were able to take folks that had no insurance at all. And as you know, those folks, you know, it's a population that we're hoping with a lot of the health exchanges that are happening and the connectors and things that are happening around the country, that there's a less and less population of no insurance. And but it was nice that we could offer these services to them as well. So the amount of monitoring and how we did that were a couple different ways. There are, each participant in the grant can have up to 5 home on-site visits. And I don't necessarily mean home, because some of our folks actually have met in the library to have a coaching session or a place that's convenient for them. Some of them are in adult day health centers, so we meet them where they are. But it's not always done by an RN. Of course, the initial visit is with an RN, and it's our case manager or one of the nurses from the VNA or Circle Home to go out and meet them and admit them into the grant. But we've done a lot of work with non-clinical interventions of community health workers. I'm going to spend some time on that because I really feel that that was where our biggest cultural change, if you will, from a traditional medical model of a home health agency to be introduced and understand how to work with a workforce out there that really fills the gap of the social model that as clinicians we just don't have the luxury of time to dig as deep as we've had. We'll talk about that a little bit more as well. So we also used Philip's technology of telemonitoring services for home, and we were able to measure their vitals through our case manager here, and we would set them up with several times a week where we would be checking their vitals, weight, blood pressure, oxygen, and looking to see if anything was flagging, which was indicating that something was off track. Now, sometimes it was the grandkids were standing on the scale, of course, but for the most part, they were legitimate flags, and we were able to do, and we've been able to prove, some strong interventions. For example, because it's a 24-hour or 7-day-a-week business, our weekend nurse manager that was filling in as the case manager on weekends noticed someone flagging, was able to contact them, do some intervention with getting a hold of the physician, and was able to change the medication at the home and have one of our nurses that was also working make a home visit, get the intervention done at home, and avoided a hospitalization. And that's the power of being that kind of triage link between the physician and the patient and really being the coach and the champion and the advocate on behalf of the patient. And it's no surprise that folks that have been on the telehealth monitoring for a year really don't want to come off of it. You can go to the next slide. This I wanted to share with you. This is a sample of all 14 grants rolled together, and you know, in the first quarter of this year was a kind of a look back to see, all right, everyone should be at their full enrollment now. How are we doing with really taking care of those uninsured populations and the target population that we were striving for? And it's really, you know, welcoming to see out of all 14 grants that we were able to stay within the thresholds of really predominantly working with those that are deemed underserved and met the target populations of Medicaid, dually eligibles, which is Medicare and Medicaid eligibility, and the Commonwealth Care is the kind of Mass Health, if you will, and plan for Massachusetts. And only 7% were commercial, and we kept it under that 10% Medicare threshold. So I just thought that might be interesting to share. Not easy to do because you want to bring on, especially when you're a home health agency and your bulk of your population is in fact Medicare, there's so many people that you do want to be able to offer it to, and it gets a little tricky. So you can go ahead to the next slide. So on, who was involved in this and who are the stakeholders in your community, and just as mentioned at the beginning to kick this off that, there's a longitudinal commitment here to really link up with your community-based partners throughout the health system, whether it's the insurer, the hospital, the skilled nursing centers. But, we really, an area that the Home Health Agency had not spent a lot of time was understanding some of the local community organizations, whether, we did blood pressure screens and those kinds of things at the senior centers, but in Lowell, Massachusetts, it's a real melting pot for a variety of cultures. So we have the second largest Cambodian population outside of Long Beach, California. I didn't know that before. We have a very large Portuguese population. We have a very large Spanish-speaking population. We have, a strong Swahili-speaking entity in Lowell. So we have all these different cultures here, and each comes with their own unique needs and resources. So places like the Cambodia Mutual Assistance Association was an organization we didn't really know much about, but after we went out and met with them, we understood that they're kind of a one-stop shop to help these folks that are either new to the country or that speak limited English to navigate their way through our Western culture, and helps them from everything from getting job applications or English as a second language courses, learning new skills so they can be participants in the workforce, helping them with housing, all kinds of things. So as we were meeting with them, one of the people that were there happened to be a community health worker, and we said, aha, will you join our crusade and be a link so that we can help to get more of the Khmer-speaking community enrolled in the grant. So that was a huge movement for us and a very new place for us to look for business. The Community Health Center here in Lowell has a curriculum. They actually train folks to be community health workers, and it's gained wide recognition throughout the state, and a lot of their work is being adopted right now into a statewide certification and beyond the state. So they were actually written into the grant, and we've used a couple of their community health workers are assigned to the grant, which has been wonderful. The other strong partner is the hospital system here called Circle Health, and the PHO, the Physician Hospital Organization, actually wrote in support of us participating in the grant and helped us to be awarded the grant. So they've been a real big stakeholder, and but just because they agreed to it doesn't always mean that things happen without some effort. So we'll get into that next, I believe. You can go forward. So how you develop these collaborations is directly in line with how we were able to grow our enrollment. And, I mentioned about the Physician Hospital Organization. They did send out a memo to all their roster of patients, introducing them to the grant and encouraging them to enroll. And I think out of, a couple hundred patients, we got 2 enrollees at the onset. So we knew we had to do something a little bit different. We really need to, step back and understand, where are we within our community? Who do we know? Who don't we know? And who has the best relationship already with some of these potential stakeholders that I mentioned before? Many of your boards have great access to people that we don't typically think about. So utilizing them is an important piece to do, and keeping them updated on new innovative ideas that you have that they can help spread the word and help channel you to the right people works very well. The other piece is our staff, because as I mentioned, the staff, was treating patients. Well, what's the #1 reason why you have to discharge the patient? They're no longer homebound. So we had to create a top-of-mind awareness, and we made it fun, and we did some prizes and things to get our nurses that are out in the field reconnected with the mission of the grant and the enrollment process. And that was a huge success and an untapped resource. So as folks were moving from a skilled service, they were extremely appropriate, of course, if their insurance for the grant was correct. They were perfect to be added to the grant. So that was another important piece for us to use. When we start meeting with the different organizations, so as I mentioned earlier, the Cambodian Mutual Association, we need to understand what are they trying to, what are their initiatives out in the community and for the year for themselves, and strategically, how can we maybe help each other and create those win-wins for each other. And it really, they were trying to get better connected to the medical community, and we were trying to get better connected to the community at large with the Cambodian population. So it just worked out great for us, and they were on the radio on our behalf and did all kinds of things, collaborated with us to have health fairs at the Cambodian Mutual Association, which hadn't happened before. So a lot of different things happened, and there's also another place called the Massachusetts for Spanish-speaking or Portuguese-speaking services. It's called MAPS here in Lowell, and another wonderful resource that we just didn't know about, and they were 2 blocks away from us. So so that was pretty interesting. And then there's nothing better than getting, I put the face-to-face, it's kind of a little pun, there's a lot of pressure on all of us to get that face-to-face in from a reimbursement perspective, but it really is better to meet with these groups live instead of sending out letters. And once we were able to get a couple of case studies under our belt, we actually used the physician-to-physician at the PHO meetings, and we created a case study for one of the doctors to present to their colleagues. And I tell you, following that really opened the floodgates for more referrals to flow to us. So, it's okay to go in and brainstorm together and try to figure out, what could it look like, what if, and if you had a whiteboard and didn't think about money at first, how could we solve some of our problems that we are struggling in our own silo, as you heard earlier. How do we spread that out and maybe collaborate a little bit more together? We did have folks from other organizations come and speak to our nurses here on a variety of different topics from different, there's areas on aging or ASAPs. I'm not sure if you have some of those in your markets. But elder services organizations, some skilled nursing centers are doing some really unique things, and our nurses just aren't aware of how to tap into those. The 30-day readmissions and using a skilled center instead of the hospital. All kinds of interesting things start to bridge when you're out there face-to-face. Okay, you can go to the next slide. So then the big piece was on, integrating our social support model. We really had to step back and help our nurses peel back and think about all the non-clinical stuff that happens in their day. And it's quite alarming, and the list was growing and growing and continues to grow. But they're so used to kind of owning it all, not to overuse the Frozen movie, but we did have to do some letting go around here, and that comes with a little time. But as they started to build trust with their community health worker and realize that these folks have had training on boundaries and ethics, and they know they're not to solve problems or try and diagnose anything in the patient's home, but they are there to be a coach, and as they can be the eyes and ears and have the time where our nurses don't have it. They can be that connector to ensure the transportation that's needed happens, or they can look and observe. So, we can sometimes call it observation therapy, right, where they can actually observe them taking their medications and really looking at the medication bottles and figuring out and then reporting back and up through the case manager to figure out, does that individual need a social service visit? Do they need a nurse visit? Should there be some sort of intervention that's happening? Typically, the community health worker is introduced to this type of model as an interpreter, and they actually go on medical appointments, and they can be present at family meetings, and it's just great to have that consistent person that starts to really bond and help them in their readiness to set goals, and then help them to achieve some self-management goals together and get them connected to resources that are in the community to help them do just that. So we incorporate them in our interdisciplinary team meetings, and they're a big player, and are able to catch things that maybe a typical nurse that has many cases and visits in a particular day just can't spend the time or get to that real root cause of why someone may be deemed non-compliant when in fact, one case, the individual, once we got down to the root cause with the community health worker, we learned that the patient was not able to afford groceries the last couple of weeks and was getting her meals from the food pantry, hence her sodium intake was going up and her weight was increasing, and the doctor thought that she wasn't managing her meds correctly. So little things like that can paint a big picture. Okay, we can go forward. So right now we're in the throes of really looking at our outcomes, and it's not all in because we had probably the Q3, Q4 we really grew the most in our enrollment of last year. But I can tell you, just looking at some early trends, we are definitely seeing less ED visits, and we are seeing when folks do go to the hospital, they're not staying as long as they were prior to the grant. So we had to look at pre-grant hospitalization utilization, as well as ED visits. So we're trying to compare pre and during at this juncture, and it's looking good. The satisfaction surveys, as I mentioned before, everyone seems to strongly recommend it. Our goal is we're beginning to work on some pricing models and testing it on a case-by-case basis. As we have, you saw there was at 7% of commercial patients. We're identifying some of these commercial plans where patients are on the grant right now and are ready to line up some conversations to say, geez, what if this person, could we extend them on the grant, and would you pay for that as a way to kind of pilot this? Because as we know, telehealth is not, and telemonitoring is not widely reimbursable at this juncture. So we're trying to continue to build our case for the good of all to get this to be a regular and a reimbursable option. We really feel like it's working. Physician support has been tremendous, and they don't want their folks to come off of the grant either. They love the personal touch and the enhanced communication that they're able to get from us. Next slide. So I wanted to leave you with a few resources. One is the curriculum that the Community Health Center has created, and thought it might be fun for you to take a look at it. If you have a similar program in your area, or if you're trying to get something like this started, it's a nice sample to use. We created the next tool, which is, we call it the Community Health Worker Encounter Tool. We needed something for the community health workers to have when they made their first initial home visit. And you'll see on there, there's lots of questions, and they're not really clinical in nature. But that overlaid with the care plan of our clinicians really makes a comprehensive care plan. And we've actually taken the information in this tool and have adapted our existing care plan and our EMR system is called Cerner, and have made some adjustments there. I would ideally like to see this used in there's some new handheld devices out there. Another place one company that's doing this and getting some really good evidence-based data back, they're called Care at Hand, and you can take a look at them online. And that's using like an algorithm to give the case manager alerts from questions that the non-clinical caregiver is asking. It converts into a high, medium, low alert to do some interventions. So take a peek at that online too. And this tool that we created in a PDF form would be ideal in obviously a tablet tool as well. And then I put the link. Philips has a hospital-to-home program, and you can learn more about that online as well. And I think that's about it. I'm happy to take any questions.
Wonderful. Wonderful, Sharon. Thank you so much. There was a lot of information there. So please, if you have questions, put those into the Q&A box, type them in, or into the chat feature, and we'll address those and ask Sharon. So any questions that you think about. I have a couple to get us started, or points I thought maybe we could talk a little bit while we're waiting for some questions to come in. And my first one, well, it was really the point that you said about talking about dual eligibles and about changing the mindset of the clinicians, that you did use some fun and games to really try to change that mentality of just doing skilled acute care for home care and then discharging, but then instead thinking about the longer scope of getting those over into your pilot or into your study. And to me, that just is the exact same way that we need to care for patients that are dual eligible. As soon as we admit them for Medicare under an acute care episode, we need to be thinking immediately into when I have to discharge them, they no longer qualify for Medicare. They have Medicaid. How can I transition that? What services are available? What could I get? But I find mostly we're just so busy as clinicians that's difficult to think about at an early stage, and then it's time for discharge and we're either out of luck or we're not able to make those connections. So some insight from working with the clinicians and having some success in thinking beyond just the acute care episode.
Right, and actually we had our steering committee meeting just an hour ago, and at Circle Health, the acute health system, I also sit on their population management diabetes task force team, and one of the big pieces we're trying to get our arms around now is creating a resource kind of guide for all of our clinicians throughout the community. So as you have folks come through, whether it's through the health center or through home health or at the physician's office, that the biggest thing clinicians need is, I don't know where to send them. So even little things of who has what support group on what days of the week, just little stuff, and who runs that, and giving them a name. The mall walkers and different little things that are around that we're trying to do this in a collaborative effort, and really, as a home health agency, the more you can plug in upstream, with your other partners in the community and the health system, and then, these non-clinical programs that are out there, it's really worth it to sit down and learn about them and come up with some sort of a resource tool for your staff, because it just makes them, brings a value add as they're engaging with their patients.
Absolutely, and there's no way today that we can keep track of any of the resources, and a lot of agencies, especially smaller home health agencies, are strapped with having social workers, and it isn't just for the social worker. And there are many community services that we aren't aware of and that we could really tap into, just like your example of the Cambodian services and community health worker that you were able to reach out to. That was a delightful surprise.
And the pharmaceutical companies are very good. We were fortunate to work with Novo Nordisk, and they, printed and gave us with no charge, and you know what, it doesn't even have their name on it anywhere, but things for our diabetic population that help them, because these folks are non-homebound, we now have resource tools for those that are shift workers and managing your diabetes as a shift worker, or how to prepare for your vacation as a diabetic, and just these little tools that the community health worker or the nurse or the social worker can kind of go to and pull out as needed instead of shoving a bunch of information all at one time at the individual.
Great. Now we have some questions coming in. Keep them coming. We're going to go ahead and address those. First, we have from Pamela. Can you repeat the information about Care at Home tool or program? I'll let you explain that just again, but I do want to let everyone know that all the handouts for the PowerPoints today, as well as the 2 handouts that Sharon talked about, are posted on HHQI website under Up tab. I'll go down to the presentation from today's event. But if you could kind of just quickly explain what the Care at Home tool and program information is.
Sure. And I can forward you, Misty, the case study that they did, and we can put that up on the website as well.
Perfect. Perfect. That would be great.
Care at Home is a handheld device, so it's a tablet, and it asks a series of questions that are non-clinical in nature. So maybe it might be things like, was your shoe tighter today than yesterday? And by the way that they answer a series of these questions, and the clinical team can pick and choose and customize the questions to fit the diagnoses. But then as you load that in, you give it to either the health coach, the community health worker, it could be a family member. And they, if it's daily or whatever days that you set up, they answer those questions. And the responses come back to the case manager in the form of a high, medium, low alert. And it's never, you know, if it's a 911 thing, then obviously it goes straight to 911. But the case manager that can organize and prioritize the how quickly they're going to respond to something. And it helps their workflow of their day, because the flags and stuff that's coming at them can be quite daunting. So that's really what it is, and they've used it on about, I think, about 7,000 or so patients now, and it's really been amazing the outcomes that they're getting. But I'll be happy to send the case study over.
That would be wonderful, and I thought it was an excellent way that you had a physician present that to the physicians at the PHO too, and so that, you know, again, it's how best to learn from real case scenarios. And that technology is being done, and research has been showing to be very effective with disease management and self-management principles in a lot of fashions. Even in physician offices, they're using that type of technology to doing some of the screening as well as the teaching pre-visit, and then it's continued to be educated on throughout the physician visit by the nursing assistant, by the nurse, by the physician, and the research is showing that to be very effective, as well as in other community settings as well. So great. Here's our next question, and it comes from Melody. She actually has several questions. Did the community health workers go through a certification program? And I think when you see the Spring Comprehensive Outreach Education Certificate Program and the modules are listed, you'll see that, but I'll go back to the question. Did they go through the program, and how were they paid for their time? Also, how did you introduce the community health workers to the interprofessional team? So I know that was 3 questions there, Sharon. Sorry.
No, it's a great question. And here in Massachusetts is a little unique because there is a certification program, and not all states. I think Vermont has one as well. The Community Health Education Center at the Lowell Community Health Center, that's why it's called CHECK. That's what it stands for. And you'll see that in the brochure. And you'll see all the modules as well. But that is a certified program that they do go through, and they offer that. They used to offer it free because they had some federal funding to do so or state funding to do so. Now I think they charge $125 for folks to go through. And we had accessed, built into the grant to pay for I think, 12 hours a week of the community health workers to be with us. So that's kind of how that worked for the grant. And we would like to look at bringing that type of workforce within the VNA, and or as we are now partnering more with the health system and the health center through Circle Health, there may be opportunities to kind of share these resources across the continuum instead of, again, trying to self-fund it in your own silo. So, you know, these folks would be great to go into a physician's office and follow up after someone just came in that was newly diagnosed or such, and they can call them and say, hey, did you really understand what they were just talking to you about your diabetes? And half the time they said yes to the doctor or the nurse practitioner, but when they got home, they don't have a clue what just happened. So catching that early on is another place that, again, collaborating through the whole health system may be a value add. And they're not, obviously, clinicians, so it's a lower cost workforce to think about as well. And then your last part of that was?
How do you introduce that? To the interprofessional team.
That was the most fun because when I read the grant and said, oh, there's community health workers, I thought, oh, that's cool. But when you can't just plop a non-clinical person next to a very traditional case management nurse or diabetic educator or regular nurse that's seeing patients and just think they're going to figure it out on their own. We really had to step back and educate ourselves first on the whole breadth of what a community health worker does and what their training is, and then slowly integrate them into the system, which really meant enhanced communication. So we started having joint meetings together, and together we peeled out all the non-clinical stuff that happens in the day in the life of a nurse as a home health nurse, and started saying, geez, you know, what if they took on a couple of these? And then slowly but surely, there were joint visits together. And then they realized, wow, this person's able to really connect at a level that I'm not able to get to. Then you start seeing them leaning on each other and sharing ideas together, and that's when you know you got it.
Wonderful. And I think also you can kind of take that same information and apply that to home health aides. If you already have them in, we tend to underutilize those, again, based upon state law, but we can utilize them as a resource and eyes and ears for us with education. It's surprising how much they're able to provide to care. To give you, there is another one of our up webinars that kind of did use some more community workers in education. So for those that are interested too, if you weren't not able to participate in the Everyone with Diabetes Counts, the impact on rural southern West Virginia, it doesn't really matter. It talks about a self-management program, and it's in our archives under the Up tab, and it was an April the 9th call. Everyone with Diabetes Counts. So that might could give you a little other suggestions working with community workers as well. All right, we have another question. These are great questions, everybody. From Mary Lou. What are some of the functions of a community health worker? I think you kind of touched on some of those already, maybe a few more examples.
Sure. Again, just because of the area that we have, most of them are also helping as an interpreter. So they may do a joint visit with one of the nurses or social worker that does not speak the language that the patient does. That's one way. They also can go to physician's appointments and help bridge, not only from being an interpreter, but what we're finding is because the community health worker is hearing the same thing from the physician, they can help reinforce it a little bit better and maybe restate it differently to make sure that the patient truly does understand. So that's been a really neat thing to see. They also help coordinate transportation, making sure they get to the appointment. They set goals with and you'll see that on the encounter form. That's really kind of their worksheet. But they helped identify the readiness of goal setting which was a big learning curve for our folks. And all of us as healthcare providers, you want to go in and preach and teach and share all your good knowledge. But if that person is not at a place where they're ready for change, you have to kind of meet them where they are and help them. And we use this like ruler to figure out where on the change curve they are. And it really helped the team on goal setting and have better sustainability and engagement of sticking with these goals. Because remember, the folks on this grant are they've committed to hanging in there with us for a full year. So we have to provide enough value-add reasons for them to want to stick around with us. And hopefully, you know, the coaching and the tools and things that the community health worker can share with them and get them connected to resources. Like in Massachusetts, there's something called Healthy Living Centers of Excellence, which is a chronic disease workshop of 6 weeks. It's a Stanford evidence-based model, and they go through this for 6 weeks. And you know, you start with a goal might be, I'm going to make my own doctor's appointment phone call. So it can be a very, very small but meaningful goal that someone sets, and it helps them to build incremental, see what incremental success looks like, so they can continue to build off of that. So that's kind of where, and the community health workers have been trained to be leaders in those workshops.
Perfect, perfect. And Sharon, I'm just very impressed with your program. You're using all the evidence-based strategies, not only for collaborations, but also the new trends in self-management and being able to continue to make progress in improving patient outcomes. So kudos, and I'm thrilled, not surprised that you're having great outcomes and with your project already.
Hopefully by October, November, we'll have real data that we can circle back and share with you.
Well, good. And we will we'll get the case study and we will post that. But make sure you do download. I think the information is interesting of the handouts that Sharon did provide for us today. So do get that under the Up tab. And if you have any additional questions, go ahead and continue to put them in, but I'm going to go over some additional resources with working with collaboratives, as well as some information and updates for Home Health Quality Campaign, because we actually are closing out phase 3, so I'm going to tell you what's going to be happening with that. So let's go over some resources that we have that may help you with your collaborations. Just a getting started, our call with the people that are on the call today or those listening to the recording, you may already be very advanced and involved in collaborations just like Sharon and her team, or you're working towards that. But some people are still trying to get started. So just some simple tips in the Underserved Population Best Practice Intervention Package on page 21. Might just get you started, get you to start having a dialogue with your leadership, with your team, with your staff. Then the additional resources, I broke these up into some components. I will let you know that these are actually being included in the update feature that will come out, I believe it's next week, that will be coming out. But these are highlighted and linked to the correct best practice packages. But if you're looking for inpatient settings, such as hospitals, nursing homes, IRUs, or LTACs, here are some setting or BPIPs, as well as some additional resources that are linked here to help you look at reducing hospitalizations, care transitions, and using post-acute providers more effectively. The next one is for how to collaborate better with post-acute providers. And that can be your EDs and urgent care. And there is a Underserved Population webinar that we had that was excellent from Rhode Island in their collaboration that they did. And some good tools and resources are available within the links as well. But you can also look for how do we work better with primary care docs, even just as simple as a doctor reminder notice, getting patients to remember and who their transportation is with. We need to look at how do we know that if they're taking their meds more correctly. We can use the Moraski medication assessment tool as a clinician tool. So again, some tools and resources, Think about other community providers, such as your area on aging associations. Many of the care transition projects that are occurring through the QIO work, a lot of those do have area on aging that are involved, or through the other care transition projects. So they're now becoming a lot of health coaches, and we can tap into the resources all the way through our post-acute providers. And then there are some additional topics on this slide. Pharmacies, and we heard Sharon talk about, pharmacists, and they're very willing to work. And I do know that I know some of the chain pharmacies will even come and help do health screenings and health clinics, and they provide resources and education materials. But they can also be that collaborative to help working on a problem. If you are going to be working with either an acute care or a post-acute care collaboration, invite a pharmacist, invite some pharmacies to be involved. Medications are involved in between 30 and 45% of our hospitalizations, so take advantage. Their role is being redefined as to what it really was originally, so they're really looking at educators. And I can tell you that there is some legislation out there right now looking at paying pharmacists to have a more active role. Unfortunately, it's in the inpatient setting right now, and perhaps some of the outpatient settings, but not for home health at this point. But you can see that is moving. The value of pharmacists is starting to be recognized from an overall perspective. Mental health centers, I mean, a lot of our patients have depression or have behavioral health issues. We provide home care services in our silo. They provide the outpatient mental health in silos, but we could work together and bridge together and utilize resources, or be that perfect handoff, or where we really are set up a nice partnership to be able to send patients to and from, provide and share information, and try to have as much transparency as possible. So some really good examples. Another really good webinar we had was on the Alzheimer's disease, a new way to understand home care system, and community mental health on wheels, and from Cleveland, Ohio, the success that they had in building their home health behavioral component, as well as a success story from North Carolina, I believe, where they found that they still had that need, and they ended up creating their own outpatient as a second part of their business so that they could have that nice transitions of care. Community outreaches, and when you think about flu clinics and screenings that you're already doing, what about incorporating some of the other components of diabetes? The more that you might be able to identify some of those diabetics, that large percentage that are undiagnosed yet, thinking about falls as being a problem. So there's some great resources here to provide. And food banks. Food bank, Sharon mentioned already as being that problem, and we've heard that repetitively. Patients' weights are going up, but they're working off of, look at a box of Kraft macaroni and cheese and some of the other things that get donated because it's inexpensive and it's non-perishable, but it's cans of soup, things that are very high in sodium. Actually, a really good tip that was in the underserved population BPIP was to work with your food bank, do a collection, do a sheet on what are good foods to donate that are low in sodium, or that are heart-friendly or diabetic-friendly. You can kick that off, in your own agency, but then you could also provide those education and resources for the food bank to be able to hand out to other communities, other faith-based organizations that might be collecting. So it's a way to, your population is already using the food bank services, or do they even know where the food bank services is? Going back to what Sharon said about knowing where the resources are and knowing how to get to the resources, what day of the week they are, and what about transportation for them to even get there? Can they send somebody in their place? Faith-based organization. Here's some links here because we have to reach out. There's only so many dollars to pay for care and services. And looking outside in the community health workers and to the community services, transportation is a great example. A lot of agencies we work with, even on this call, are rural, and they have issues. Transportation is a huge problem, getting them to and from doctors to be able to get their medications, to get food, etc. But sometimes creating that network, an interface network where you're able to tap in for those type of resources, that churches are willing, to find people that are retired that would be willing to do some driving and to take people somewhere. So we have to look at those resources, and we can't leave those to just our social worker. We, as leaders in our organization, have to create these collaboratives and this so that we're able to tap in those to meet those needs. And obviously, because we saw that Sharon had this wonderful grant through Blue Cross and Blue Shield, that we need to look at our insurers and payers. And there are tons of new and innovative projects that are out there. There are a lot of grants out there. There are Medicare, CMS is doing new types of payment models, even for home health. I did start listening to the Open Door Forum call today, and it is posted on the website. If you missed it, you can listen to the recording within the next 2 days, I believe, as well as believe we put a posting out on our Facebook, the new condition of participation changes, the PPS changes that are coming, but they're talking about the new model, the value-based purchasing, where they're going to do a pilot in a different payment system in rewarding or taking away money for those related to outcomes. So again, this is going to continue to change. People are looking to try new things, new ways, because we have to find a better way to provide health care more effectively, more efficiently, and patient satisfaction using that triple aim type of fact. And academia is one that we kind of forget about. We can create partnerships here to help do to do some of your data analyzation, to assist with your collaboratives. You can have them do a thesis or a project for school. We do have one example that is posted under the underserved population. And I'm going to go ahead and move into some announcements as we wrap up this phase 3. The Underserved Population Assistant Network has only been up for a little over a year and a half now, focused on 4 different areas. Those underserved regions in the country, or areas, it can be anywhere in any state, but underserved regions, dual eligible patients, health disparities, which includes a ton, and small home health agencies that really do not have the resources to provide a lot of QI and to sustain that. So that was the focus of the Underserved as we started. There was the Underserved Best Practice Intervention Package, which was the primary package that came out in February 2013. We also have the Underserved Network events like you're on today, and we will have this session up tomorrow, and there will be 26 archived sessions, and it includes everything from caregiving and care transitions, collecting and using data, disparities related to health, cultural literacy, poverty, disease management. There was Alzheimer's, diabetes, compulsive hoarding, nutritional gaps, dual eligible and working collaboratively with managed care. There were several sessions. Hospice and palliative care, mental health, outcomes, and proactive measures for QI, surveys, and your MAC audits. So those are some of the topics that are there. They're available. We also have our update, our e-newsletter. It will come out next week. So we want to thank you for helping to make that very successful in our inaugural work, and the underserved population is there, and many of you have been working on it. We hope that we've been able to provide you some tools and resources. And another resource is the live chat, which is this Friday from 2 to 3 Eastern Time. If you've never participated, it's great. There's no audio. You just type in your questions. It can be on any topic, and we'll try to find you resources, and we chat amongst each other, home health agency to home health agency, sharing tools, resources, and ideas. You can always connect with us through Facebook, Twitter, LinkedIn, etc. Now, let me tell you about phase 4. We're currently the end of July, we finished phase 3. So what happens? Well, our campaign site, the HHQI National Campaign site, it will be in currently a brief static period to prepare for new and exciting enhancements that will launch soon. In the meantime, you can continue to enjoy all of the archive tools and resources contained within the site. Please check back often, and we'll share details on the campaign's next phase as soon as it's available. Now, with the UP Network, there are no additional UP Network events scheduled at this time, but all those archives will remain available. With data access, if you're using the HHQI data, it will currently also be in a brief static period to prepare for new and exciting enhancements that will launch soon. In the meantime, you can continue to access your archive data reports through May 2014 on this website. And I'd like to thank you for taking your time out today. I thank you for the great questions. And Sharon, I would like to thank you so much for your presentation, your expertise in working and being a really great role model in today and sharing your successes with how we continue to see home health emerge and evolve.
Thank you.
So with that, I'd like to thank everybody.